Okay, so complement, right? Now, complement is a whole range of small proteins which, when interacted together, when these small proteins interact together, they can give you a first line of defense ish, immunity. Now, this is in the blood, and usually it's easy to activate. So you don't need to bring in cells; it's already proteins which are in the blood, and when activated they can mount a small defense against the bacteria. Now, because these are proteins, we know that they would be synthesized in the liver and they're in the plasma. Now, also they're a part of innate immunity. Now, the most important thing about the complement is the MAC, which is the membrane attack complex. Now, everything that happens in the complement, it's ultimately to produce MAC, the membrane attack complex. And now, what do you guys think? What would the membrane attack complex do based on the name?
Kill.
Yeah, it will attack the membrane and kill the bacteria or the virus. Technically, not viruses, but bacteria. And more specifically for the gram-negative bacteria. Now, we have two classic pathways, which are either IgM or IgG mediated. And what happens is whenever you have an IgG or IgM, you can activate complement. Now, IgM and IgG themselves can have functions such as opsonization or chemotaxis, but additionally, they can also activate complement. Next, we have an alternative pathway. It is actually called the alternative pathway. And this is just activated by the surface molecule. So it could be LPS or LAS, which activate the complement. Finally, you have the lectin mannose binding. So there sometimes some bacteria they have a mannose sugar group on their cell wall. Now, whenever your complement binds lectin, which is a part of the complement, so whenever it binds to this mannose, it can trigger the complement activation. So remember that mannose is a sugar on bacterial surfaces. Yeah. So if you remember this part, because it's a lot of memorization, but if you can remember this portion, then I would say you're already done with like 50% of complement. And the next is you need to memorize these functions. So this protein is important, the C3P, which is responsible for opsonization. And after that, this one is important, the C5A, which is a chemotaxis for neutrophils. And finally, the remaining things, so C5B to C9, that forms the complement. Now, okay, here's an interesting question. So let's say you have a deficiency of the MAC, the membrane attack complex. So what kind of bacterial infections are you at a higher risk for?
Neisseria meningitidis.
Yes.
Neisseria.
Yep, perfect. Now, there is one more interesting thing about the inhibitors of complement. Now, complement, it's present in the blood, right? It's present in serum and in blood. So why do you think we would need inhibitors for complement?
So they don't get activated and damage the cell.
Yes, so that they don't, I mean, we want them to get activated and damage cells. We just don't want them to damage our cells.
Yeah.
That's the difference. So the thing that your body does, right, or it has an inbuilt defense, and this defense is two receptors actually. It's the DAF receptor, or like the DAF protein, and the CD55 protein. Now, what these proteins do is they prevent the activation of complement on RBCs or our own cells, and we want to prevent that. And if you have a deficiency of DAF or CD55, then you can develop something called as paroxysmal nocturnal hematoglobinuria, which we will study soon. And then also C1 esterase inhibitor. Now, Let's take the name C1 esterase. So what do you think C1 esterase does?
It helps in activating the complement, like alternative pathway or classic pathway.
Yeah, so it helps activate C1. That is how C1 esterase. And then if you're blocking C1 esterase, then you're preventing the activation of complement.
Yeah.
Yeah. So now a very quick like recap, because there's multiple different parts to the complement. You have C1, and C1, whenever it's activated, it will give rise to C3. C3 will go to C3b, and it can go to C3 or like C3b through C3 convertase. That's the enzyme here. And after it converts into C3b, then it can convert into C5b. Basically, it goes C3, C5, C5 convertase, C5b, then it combines with everything else, forms the MAC, which can then kill a bacteria. Now, in the meantime, it also produces a lot of these branch proteins. So you have C5a, you have C5b, you have C3a, C3b, uh, C4 has variables. So all of these. But remember this as the most simple part, that you have C1 gives rise to C3, gives rise to C3b. Okay, C3b is produced. After C3b, it goes to C5, which can then produce C5b, which combines with all the other complement proteins and forms the MAC. So that's a very simplified version of complement. So did you guys understand the part, or do you want me to write it down just once?
I'm okay.
Okay. So those are all the things you need to remember about complement. So also, any questions with complement?
Mm, not really, actually.
No. Okay. So that's all right. We'll go through all of these concepts a couple of times again. So when we do questions, we'll go through these, and then again when we do like the quiz at the end, we'll also go through these questions.
Okay.
Okay. So next we have the complement disorders. Now these are also pretty easy to remember. We already know that a terminal complement disorder will give you increased Neisseria infections. And then one thing that we need to know is that if you have a C1 to C3, sorry, C1 to C4 complement deficiency, you'll get an increased risk for SLE. Now, one way to check that you have decreased C1 to C4 is actually by a CH50 test. And if the CH50 test is low, then you can confirm that this patient has a decreased C1 to C4 complement proteins. And then what do you guys think? What would be the symptoms of SLE?
Mallow rash,
Mallar rash.
joint
That's important. Yeah. Joint pain. Okay. What about the mouth? What symptoms can you see in the mouth?
ulcers, right? FTS ulcer.
Yeah. So you can see ulcers. Okay. FTS ulcers could also be possible. Now, what about skin? What will you see on skin? Except for Mallar rash.
They're SLE are photosensitive.
Yeah.
Yeah.
With the sun they'll get rash.
Yes. You'll also see photosensitivity. Now, what is another classic rash? Except for Mallar, you have another classic rash for SLE. It
Is
starts
that
with
macropapular rash?
oh
Oh,
no,
discoid rash.
yeah,
Discoid rash.
discoid rash. So those are two: Mallar rash and discoid rash. These are the two buzzwords you need to remember for SLE.
Okay.
Now, remember when we talked about C1 esterase, which prevents complement activate. Sorry, C1 esterase inhibitor, which prevents complement activation against our own cells. Now,
Mm-hmm.
C1 esterase inhibitor. Some patients can have a deficiency of this enzyme, and when you have a deficiency of this enzyme, when you have a deficiency of this enzyme, the most common thing that you'll see is actually something called as hereditary angioedema. Now, this condition, usually they'll give you as a presentation, usually they'll give you a kid, maybe Asian descent, and he would just be very puffy. I don't know if there's another appropriate word to describe it, but he would just be very puffy, like very swollen. Now, that's how they generally give you the presentation, but there's a new way of giving the presentation where they might also tell you that there is an elderly patient who was recently taking some ACE inhibitors and now recently developed laryngo swelling. Sorry, not laryngo swelling, but compression of the trachea. Now he cannot breathe properly, laryngoedema. That is also a possible presentation for hereditary angioedema. And now, why does this happen? It happens because of the increase in bradykinin.
It's the same pathway as the cough with the ACE inhibitor?
Yes.
Just worse?
Yeah.
Okay.
It's just much, much worse. And actually, you ruined my other question. I was going to ask which one is the most common side effect of ACE inhibitors. Okay, what's the second most important side effect of ACE inhibitors after cough?
Teratogenic.
Okay, they can be teratogenic. What if the patient is not pregnant?
Okay.
What about electrolytes?
Oh, increasing
potassium.
potassium.
So lower potassium.
Lower potassium.
Lower potassium or higher potassium?
Higher, right?
Higher. I
Higher?
thought it's higher.
Higher or lower?
Yeah. Higher potassium.
Higher or lower?
Higher or
Okay.
lower, both?
Both? So that would be normal. So no
Oh,
potassium
really?
changes?
Okay.
So think about
But
it.
I thought like
Yeah.
if it's not working, so angiotensin 2 would be not working at the
Yeah.
collecting rate, and where we are not reabsorbing the sodium and releasing, not like excreting the potassium. So we will have more potassium inside of the serum.
Yes, that is correct. So you don't have aldosterone because of ACE inhibition. Now, because you don't
Okay.
have aldosterone, you're not excreting the potassium, so you have more potassium. Now, because you have
Okay.
more potassium, that is hyperkalemia.
Okay. But
Yeah.
you said normal.
No, I was just messing with you guys.
Oh gosh. Okay, Dr. Taha.
Yeah, because someone was saying high, someone was saying low, so I was like, okay, if it's high and low together, then that means it's normal, no problem.
So okay, yes, it's hyperkalemia.
Yes. Now, okay, let's say someone has a problem with cough, which is because of the ACE inhibition. So, what other medication can you give him? You still want the effects of ACE inhibitors, but you don't want the cough.
ARBs.
ARBs.
Losartan.
Okay. Now, what if you want to directly inhibit the renin? So, what medication?
Beta blocker.
No, not beta blockers. Only renin. I just want to inhibit renin, not anything else.
Kallikrein inhibitors, right?
Which one?
Kallikrein inhibitors or
Kallikrein?
something. Okay. Yeah.
Kallikrein gives rise to bradykinin.
Okay. All right. Something inhibiting that. That would be C1 esterase inhibitor or something.
No, it's a separate medication. It's a direct renin inhibitor.
Oh, Aliskiren.
Yeah, aliskiren. So
It
aliskiren
sounds
is the
like
medication.
Kallikrein, so that's why I was like, okay, Aliskiren, yeah.
Yeah. So aliskiren is the medication which can be a direct renin inhibitor. Now,
Okay.
let's say I want to prevent the breakdown of angiotensin, and additionally also I want to prevent the breakdown of atrial natriuretic peptide. So then what medication can I give the patient?
Neprilysin inhibitor?
Yes. Actually, neprilysin is the name. And wait, what? The name is sacubitril?
No, sacubitril.
Yeah, sacubitril is the name. It's a neprilysin inhibitor. Yes.
Yeah, she said.
Yeah.
Inhibitor, yeah. Neprilysin inhibitor.
Perfect. So next condition that we have is paroxysmal nocturnal hematoglobinuria or hemoglobinuria. So now, based on the name, what do you think we can think about this condition? So
Something
paroxysmal,
happening.
yeah. So something that happens,
Nocturnal, yeah, nighttime breakdown of the red blood cells, and the patient will have a red urine in the morning.
yes. So that's true. So it happens sometimes, happens at night. Whatever the pathology is, it's happening at night. And whatever the pathology is, it's causing hemoglobin to be in the urine. So now, what happens at night, right, is your body develops acidosis. Now, why do you develop acidosis? It's because when you're resting, you're very peaceful. There's no danger, so your heart also relaxes. Your breathing in turn also relaxes. So you have bradycardia and bradypnea. Now, because of the bradypnea, you develop a physiologic respiratory acidosis. Now, it's physiologic because around that time, your body is also relaxing. So you develop acidosis. Now, this acidosis that you develop at night will in turn activate complement. And now, when your complement is activated, if you have a deficiency of the protecting factors, so DAF, CD55, that is one. If you have a deficiency of these and your complement is activated, so what do you think will happen to the RBCs?
Breakdown, right?
Yeah,
Lice.
they'll be lysed. And now, when the RBCs are lysed, so what do you think will happen to the hemoglobin? Like, where will the hemoglobin go if it wants to be excreted?
Kidneys.
Kidneys, and that's why you have the red urine or the hemoglobinuria. So, happened at night because of the acidosis. And why did it happen? Because you did not have proper protection for the RBCs, and that's why complement got activated, RBCs died off, and now because of that you have hemoglobinuria. And note that this only happens sometimes when you breathe very low or breathe very slowly, and you're actually able to develop that acidosis, because you don't always develop acidosis. Usually it's like a very slight acidosis, but then in this condition maybe like a little over the normal amount of acidosis, and you develop hemoglobinuria. Now, let's say you are breaking down a lot of RBCs, and there is a lot of RBCs in the, so not a lot of RBCs, but a lot of broken RBCs in the blood vessels. So what do you think can happen to those blood vessels?
They get clogged, right?
Yeah, so they can get clogged. That's one. And now, because of the clogging, you can develop multiple different problems. So you can develop Budd-Chiari syndrome. You can develop portal vein. Oh, sorry, Budd-Chiari syndrome was the syndrome. And then you can also develop thrombosis in the portal vein, cerebral veins, or the dermal veins. So now, do you guys know what Budd-Chiari syndrome is?
No.
The hepatic vein, right? The hepatic vein compression or the hepatic vein.
Yeah, so Budd-Chiari syndrome is, it's basically a compression of the hepatic vein. And there are three things you need to remember for Budd-Chiari syndrome. Is that these patients will develop ascites, abdominal pain, and also hepatomegaly. So that's the triad of Budd-Chiari syndrome.
Okay.
Okay, now a quick question. The the lysis of RBCs, the hemolysis that you see in paroxysmal nocturnal hematoglobinuria or hemoglobinuria, is that intravascular or extravascular?
So that would be intravascular.
Intravascular or extravascular?
My guess is intravascular.
Okay, yep, it is intravascular. Now, why is it intravascular? Because complement it's present in blood, and blood is within the blood vessels, so that's why.
Okay.
Next, we have these cytokines. Now, I mean, I can't help you with these cytokines. You will sadly have to memorize these.
Okay.
And I'll give you one hint though. Don't memorize all of them. That's like just too much work. I'll say memorize these ones, the simplified form. So remember that IL-1 is for fever, IL-2 is for production of T cells, IL-3 for bone production, IL-4 for IgE, IL-5 for IgA, and IL-6 for acute phase reactant or acute phase protein. Once you know that, you also need to remember this one, which is the tumor necrosis factor, A. Remember that it activates endothelium and provides a vascular leak. Now, why do you think we need a vascular leak? Or why do we need to make space between the blood vessels or in the blood vessels? Why do you want to make them more leaky?
So it does the permeability, right?
Yeah.
Increase the permeability.
Okay. So now you have increased permeability. But then
Yeah,
why
the
increase?
plasma. Yeah, because the plasma protein has antibodies, so it could reach to the inflammatory tissues.
Okay, that's one. And now what if like it's an acute sorry let's say it's an acute inflammation, you still don't have production of antibodies yet. So then why do you
Oh,
want to increase permeability?
the neutrophil macrophages
Yes,
will respond to it first.
yes, that's true.
Yeah, so we'll see a left shift.
Yes. Now I will also tell you to remember the interleukin 8 because that is important for neutrophil chemotaxis. Except for that, I mean, nothing. So you don't need to remember interleukin 12. But I mean, you already remembered all of these till now, so okay. And one more. Okay, yeah, interferon gamma is also important, and you need to know that interferon gamma it's majorly for stimulating macrophages. Oh, yeah, this one is also important because this is one of the only interleukins which can halt inflammation. So these are the two ones. So tumor growth factor beta and then interleukin 10, which can both reduce the reduce the inflammatory response. Okay, yeah. So these are the ones you should remember. I mean, ideally you should remember all of them, but if you forget some, that's all right. As long as you remember all of these. So 1 to 6, 8, tumor necrosis factor alpha, interferon gamma, and then interleukin 10 and TGF beta. Okay. So any questions with these interleukins?
Dr. Taha, can you go over the tumor necrosis factor alpha again?
Oh, yeah.
So interleukin 6, interleukin 1, and tumor necrosis factor alpha, I remember they being produced in the inflammatory conditions, right?
Yeah.
And then the macrophages are the one they're secreting it. And then the vascular leak, I remember it was for the, like any inflammation is occurring at the area. So the cytokines actually make the vessels permeable and they will go to the site of inflammation, right?
Yeah.
Okay. So this is what the vascular leak mean, right?
Yeah. So vascular leak, it just means that the I would say the amount of connection between the walls of the capillary is slightly reduced. So then it's some space for neutrophils, macrophages, antibodies, lymphocytes, all of them to go from the capillaries into the interstitium, where they can actively fight the infection.
Okay. All right, thanks.
Okay. Next, we have the oxidative burst. Now, in the oxidative burst, there's multiple different steps, but there is only, I'll say, one step which is very important, and that is this step here: conversion of sorry, yeah, conversion of O2 to O2 minus. That I would say is the most important step. Why? Because this is the only step which is associated with some kind of major problem or major condition. Now, uh, before we begin, or before we start talking about why this step is important, uh, the idea behind the oxidative burst is to kill the bacteria. Now, the most powerful, I would say, enzyme that the body can produce is bleach, which is HOCl. Now, bleach, it just kills bacteria. Now, your body doesn't make a lot of bleach, it just makes it as required. So what does the body make bleach from? It makes it from oxygen. It takes the oxygen, adds an extra electron, converts it into peroxide. Then from peroxide, what it does is it adds some chlorine into peroxide, and then in the process you just make some bleach. Now bleach is very effective at killing bacteria. So that's the oxidative burst in short. Now, if let's say you have a problem with actually before that, there's certain bacteria, right? And they're very sneaky. They understood that the body produces peroxide, and they said like, okay, if the body is producing peroxide, what we'll do is we'll hijack the peroxide, convert it back into water, so that the peroxide can never get converted into bleach. Those are the bacteria which are catalase positive. Now, a couple of things. If let's say you are not able to produce the oxygen reactive species, so the O2 and the O2 minus, if you're not able to produce this because you have a deficiency of NADPH reductase, so you won't have a lot of peroxide. Now, if you don't have a lot of peroxide, then the bacteria which have catalase will be at an advantage, because if there's no peroxide, then they can just freely neutralize all the peroxide. I mean, there will be peroxide, it will just be less peroxide. So all of these bacteria, they'll be very happy. Now, what do you think will happen if there is a lot of bacteria which have catalase positivity? And they're not, our body isn't able to kill them. So what do you think will happen?
Infection. I don't
Yes, that's true. You'll have an infection.
know. Okay.
Now, if you have an infection, and what your body does is it tries to control the infection. If your body cannot kill the bacteria, then the best idea for the body is to trap the bacteria, to trap the infection. And then one way of trapping the infection or trapping the bacteria is by producing a granuloma. Because in a granuloma, you just ward off the space of infection or the bacteria within one ball. Now, if you warded off the bacteria and it doesn't leak out, so that's good for the body. Now, what is one condition or like one reason why a granuloma might break? What do you think?
Is it the enzyme they're not producing or something?
No, not necessarily. Think about what the granulomas are made up of.
They are made up of T lymphocytes.
TNF and macrophage.
Yeah.
Yeah.
And what type of cells are macrophages or lymphocytes or neutrophils?
Antigen presenting cells?
No, like
Macrophage.
they're immune cells.
Oh,
Yeah. So now, what happens if you have less immunity or you're immunosuppressed?
okay. So yeah,
Increase infection.
Yeah.
yes.
Yeah.
So when you're immunosuppressed, you'll have a reduction in all immune cells, and that will eventually lead to a rupture of a granuloma, which can then cause significantly more infection compared to when like the granuloma was formed. Okay, so you guys understood why the granulomas are forming, right?
Yeah.
Yeah. So now let's say there are multiple bacteria which are catalase positive and they're all infecting your body. So then what do you think will happen in these patients?
So there will be a lot of granulomas will
Yes,
happen.
that is true. You'll have a lot of granulomas. And now the problem with having a lot of granulomas. So initially you started with a deficiency of this enzyme, which is NADPH reductase. Now, because you have a deficiency of that enzyme, NADPH oxidase. So because you have a deficiency of that enzyme, you started getting more infections with catalase positive bacteria. Now, because your body was not able to fight those infections, you locked the infection in a granuloma. And there's multiple different infections which are constantly happening. So you develop multiple granulomas. This condition or this stage, when you develop multiple granulomas over a period of time, is called chronic granulomatous disease, which is
Okay.
CGD.
All right.
And now we know everything about it. We know that this is caused because of a deficiency of this enzyme, which is NADPH oxidase. We know that
Okay.
it will majorly be infections with catalase positive bacteria. And why is it caused? Sorry, where is the actual name? Yeah. So why is it called chronic granulomatous disease? Because it's a chronic condition, happens over a long period of time. You have a lot of granulomas and disease. And then why do you have the granulomas? Because your body wants to ward off the infection.
All right. And then NADPH enzyme. So that is embedded on the surface of the cells, right?
Yes.
Like on neutrophils and or just the cell itself.
I mean, on all cells. So you have neutrophils, you have macrophages. All of those cells have NADPH oxidase.
Okay.
That's
And
initially
then
how they deal with
okay.
infection.
But then when they're encountering the infection, I mean the bacteria, so they engulf the bacteria and our body is trying to kill it off, but they can't do it. And that would be because of NADPH oxidase deficiency.
Yeah. So they engulf the bacteria, all right. They
Okay.
engulf the bacteria. Now, after
All right.
engulfing the bacteria, they produce a phagosome, which is just an engulfed bacteria with some vesicles. So that's a phagosome. Now that has to get merged with the lysosome, and the fusion is called a phagolysosome.
Okay.
Now, like when we study more diseases, we'll also know that there is a problem when you cannot combine the phagosome and the lysosome. So that's called Shiitake-Gashi syndrome. But here in the phagolysosome, the lysosome it merged with the bacteria. But now because of the deficiency of the NADPH oxidase, you cannot kill the bacteria because your lysosome cannot produce the bleach.
Okay. Because I was just like thinking about where the NADPH enzyme is embedded. So meaning it's on the cell itself, but it's they can engulf the bacteria normally, so nothing is wrong engulfing. But
Yeah,
the breaking down of the bacteria is with when there is enzyme deficiency, so they cannot break it down.
yeah.
Okay, thank you.
Now there is one more thing about the chronic granulomatous disease that you need to know is that there is a test that you can do. It's called the wait, where is the Okay, so that's basically, I don't think they've mentioned it here. Maybe later on. Okay, anyways, there's two tests that you can do. One is called a nitro-blue tetrazolium test, and the other one is called a no wait,
Rhodamine.
dihydrorhodamine test. So these are two tests that you can do to confirm if the patient has chronic granulomatous disease.
Okay.
Finally, we have the interferons. Now, there are three different types of interferons, and what they do is they usually form a defense against viruses. Now, this here is a very good mnemonic that interferons interfere with DNA and viral RNA production. And yeah,
Okay.
that's the most you need to remember about interferons.
Right.
And one more thing that you need to remember is that interferon gamma. This is actually an important one because interferon gamma, it activates which cells?
Macrophages.
Yes, interferon gamma, it activates macrophages. Yeah, that's
Okay.
all about interferons. No. And then, yeah, finally, then you need to remember all of these cell markers.
Okay.
Yeah, I'm sorry, there's a lot of things here that you just need to memorize, or things which are just not important in the
Okay.
basics. So that's why we are skipping over a lot of things. But don't worry, if you come across something that you have troubles with, you can just text it on the group. I'll respond as soon as possible, or we'll also go through them when we do the questions. So if we missed something here, we'll do it in the questions. And if there was something which we missed in the lectures, in the questions, then hopefully we can also cover them in the quiz.
Okay.
Yeah, so this is something you need to remember. Now, there is okay, so there is one state which a lot of these T and B cells are present in. It's called energy. This one, energy. And the state of energy, it basically means that the cell does not get activated by an exposure to the antigen. That means it's just a dormant cell. Like, let's say it's gone into hibernation. No matter what kind of exposure you give to that cell, it does not wake up. Well, that
Okay.
is in simple terms what energy is. And now, why do you think you want to put your cells? This is a natural process which happens. Now, why do you think your body will want to, let's say, hibernate few cells?
So to avoid the autoimmunity?
Yes.
Okay.
And now, let's say you want to hibernate cells because they were being activated against a specific self antigen. So, which region of the thymus will this happen in? Will it happen in the cortex or will it happen in the medulla?
So sorry, I didn't get the question, Dr. Taha.
So, let's say we want to just 1 second. Yeah, let's say we want to hibernate a certain cell, and the
Okay.
reason we're hibernating the cell is because it was reacting to a self antigen, which is an antigen of our own body. So we want to hibernate the cell because if we leave it in the blood, it can cause autoimmune like disorder. So which zone of the thymus will the cell be hibernated in?
Medulla.
Medulla. And why do you say medulla?
Because they will have that negative selection there, right?
Yes, that is correct. And then what is the difference between a negative and a positive selection?
So the positive selection is when we have the foreign antigens being presenting to our body, and then they are keeping the memory for the next time exposure, right?
No, it's
Or
it's a selection.
selection of, okay, CD4 and CD8.
Yes, it's a selection of these cells.
Okay.
So if the cell
I,
reacts, wait, I heard someone else.
oh, nothing. I was just saying that I know the positive selection is kind of like a survival reason. It's just to
Yeah.
make sure that the T cell can recognize the MHC molecule.
Yes. And then what about negative
Yeah.
selection?
Negative, I think, has like self-destruction. Negative for negativities, which is for Ben the autoimmunity,
Yeah.
which is you mentioned is that it's located at the thymus medulla to against the self-antigen.
Yes. Perfect. And now, a lot of times, if you don't want to outright kill the cell, which displays self antigens or which can bind self antigens, you can also put them into a hibernating state, which is energy. And actually, I just realized energy derives from like a lack of energy. So that's why it's hibernating, because it has a lack of energy.
Okay.
Yeah. Okay. So then I would say let's end for today. Tomorrow we'll start with active and passive immunity, and then also complete vaccinations, hypersensitivity reactions, and hopefully the blood transfusion reactions. Yeah,
Okay.
till blood transfusions.
Thank you so much.
No problem. So, do you guys have any questions before